Red Lano, Red Latinoamericana de Neurooncología.
So thank you. So we're going to talk for a few minutes about my experience with awake craniotomy and its tremendous value for use by neurosurgeons everywhere. Awake craniotomy for brain tumor removal, lessons learned from over 1,000 cases. Why should we do brain surgery awake? It avoids the morbidity of general anesthetic, which albeit is low but not zero. It's faster than craniotomy under general anesthetic, which appeals to neurosurgeons. It allows for mapping of the cortex to decrease neurological complications and maximize resection. There are less resources used, which is particularly important in the developing world, and there are less complications. So awake craniotomy produces less medical complications, less neurological complications, less resource utilization, and less cost. Which patients will benefit from an awake craniotomy? Any patient with an interaxial tumor, and even some with extraaxial. We do some meningiomas, but particularly for lesions under eloquent cortex, as this lesion just below the speech cortex in a 25-year-old man. Non-candidates are patients with major dysphasia, major confusion or somnolence, tumor location necessitating an uncomfortable body position. Increased intracranial pressure is not an exclusion. The brain behaves very beautifully under awake conditions, even with massive tumors. So the protocol starts with education of the patient. We same day admit the patient at 6 o'clock the same day. They don't come in the day before. We have an MRI for the surgical navigation system early in the morning. We have non-invasive anesthesia monitoring, steroids and antibiotics as usual, and positioning the patient very comfortably with padding. And this is a typical view of a very simple setup, nothing fancy about it. We fix the head in Sugita pin fixation using local anesthetic. We register the navigation device. We mark an adequate scalp flap to expose the inadequate bone flap, and it's almost always a linear scalp flap. Local infiltration circumferentially with the same kind of anesthetic that your dentist gives you. And we have to drape the face free near a microphone. We don't shave patients. This gentleman just happened to be bald by design, but there's the linear incision to approach the tumor, and notice the dotted ring block. We have to circumferentially anesthetize, so all of the tissues are anesthetic. And there he is comfortably sitting there while we're taking out his brain tumor. Standard scalp and bone flap, the use of navigation to locate the tumor, cortical mapping, corticotomy to avoid functional brain, and then standard microsurgical resection. We use the microscope for every intraaxial tumor. Here's an example of bipolar stimulation. We monitor the patient for 2 hours in the recovery room and then transfer to the ward. They're discharged home the next morning or the very same day, which I'll tell you about in a few minutes. And we review in my office in 7 to 10 days to review the pathology, etc. So with cortical mapping, we use bipolar stimulation with 100 microsecond square wave, 50 hertz repetition rate. Stimulated 8 to 16 milliamperes. We map for appropriate functions, whether it's speech, motor, sensation. We've even mapped for vision. We speech map by counting and naming objects in photos. Motor mapping is done by strength testing. Positive cortex is labeled with numbered tickets, and a birth of 1 centimeter respected from the positive cortex if possible. And this is just a simple demonstration of the simplest way to test motor function is just have them play the piano. Whoops. Second movie didn't show. That's okay. No? Okay. So here's an example. Here's a papillary glioneuronal neoplasm, a grade 1 tumor under the motor cortex of a young woman. There's her head. There's the shave and the incision. And there's the exposed bone with the vein of death, the Rolandic vein going across. And the surface projection of the tumor is in pink, and you can see that all of those letters represent positive cortical function. So if we did this surgery asleep, we'd probably cost this girl her leg function for the rest of her long life. She's only 15. So where did we cut? We cut where the red line is. We used the back of a sulcus, which is safe, and then a bit of a quiet gyrus, and took the entire tumor out. And that was about 10 years ago, and she's remained well and disease-free with an intact leg. Here's an example of some cortical mapping showing how sometimes the brain can distort speech function. So all of those numbered tickets represent speech, oddly enough. This was a young engineer, and there's just the surgical cavity at the end of the resection. So I mentioned that resources are minimally used. We rarely use catheters, arterial lines, CVP lines, endotracheal tubes, ICU beds. The median hospital stay has been 1 day in my very large series. And in the last 2,500 brain tumors I've done, you can see in yellow that awake brain surgery is a substantial part of what I do. And it's become a mainstream part of my practice, and I hope that it will become the mainstream part of many other intraaxial tumor surgeons' practices. So there are over 1,000 patients as of last week. This is just for a resection. There are many other, thousands of others for biopsies, etc. But this is 1,000 cases for resection of tumors. Age range 12 to 86, 2/3 gliomas, 1/3 Mets. And mapping significantly altered how the surgery was done in 1/3 of cases. So the predictive value of mapping, when mapping is positive, there is a 6% chance of a new deficit and 15% chance of worsening of an existing deficit, which gives you powerful information intraoperatively. When mapping is negative, there is only a 2% or 1 in 50 chance of hurting a patient, or 12% chance of worsening an existing deficit. So what about patient satisfaction? We did a qualitative study of satisfaction of patients undergoing awake and outpatient craniotomy, and we learned that the satisfaction level was high. Patients were initially surprised it could be done, and trust in the surgeon and or the system is very important to help them go forward with new or different techniques. So awake craniotomy is practical and easy for the surgeon, anesthetist, and patient. It's faster than craniotomy under general anesthetic. It's less resources used, so cheaper. Lower complication rates, so safer. So it's easy, faster, cheaper, safer. I'd call that a win-win-win-win. There are no randomized prospective studies that show safety, and certainly a prolongation of survival would not be an appropriate endpoint. But based on a very large experience, I can safely vouch for these 4 points. I've also had the privilege and pleasure of teaching this simple technique across the globe in various developing world settings, and these are all the first ever awake craniotomies in these particular venues. And we're hoping that this particular procedure will help surgeons in developing world situations where resources are a huge issue and the operation is much cheaper, so that patients, for example, in Nigeria, it's $300 US for a craniotomy under general anesthetic and $30 for a craniotomy under local anesthesia, so patients actually get access to care that they would not otherwise get. Maybe more in South America. I know that there are some excellent surgeons doing some wonderful work here, and our colleague Adriana Lopez has launched an excellent program in Medellin, and I'm sure many others of you are embracing awake craniotomy in South America. So I'll close with something crazy. If at first the idea is not absurd, there is no hope for it. And the crazy idea I got about 15 years ago was outpatient brain tumor surgery. And now in 15 years or 17 years, we do all the image-guided Ommaya reservoirs outpatient, all of the tumor biopsies. I guess the interesting one is the craniotomy for tumor resection. So this is 420 patients who come in the morning, have their tumor removed, and then go home the same day or eating dinner at their dinner table. And we've proven tremendous safety and efficacy of this procedure. And it's not just for small tumors. This is an anaplastic ependymoma in a young mother of 3. The post-op CT 4 hours done after surgery just to make sure there's nothing evil going on before she walks out the door. Recurrent glioblastoma. Breast cancer metastasis in a young woman. So this is, I think, an interesting procedure which I do not expect everybody to embrace, but it shows how far we've come with the safety of awake craniotomy, and it really has tremendous advantages, the main one being that avoids all hospital-based complications. If patients are at home, they don't have a medical error, they don't get a urinary infection, they don't get a deep vein thrombosis, they don't get pneumonia or atelectasis, etc., etc. So outpatient awake craniotomy is a feasible treatment option for many patients with brain tumor, at least in my system. It's probably not practical for South America, but maybe it is. But let's at least start with more awake craniotomies. I thank you very much, and I just show you my hospital, which I think Dr. Gentili may have shown a minute ago. And this, of course, is the CN Tower from the lake. And this is the not-so-pretty side of Toronto. This is the way Dr. Gentili's car will look in 4 months from now, and Dr. Lopez's car if she's in Toronto around Christmas or January. So we love the snow, but for many people in the world, it's not such an attractant, but we like it. Thanks a lot for your attention.
Red Lano, Red Latinoamericana de Neurooncología.